And with that, it is now time to start with our third and last plenary session, focusing on a very important question after 3 days of uniting nations through innovations here in Geneva. Question is, does investing in new technology in fact really improve patients' and clinicians' lives? To nicely tie together this very interactive session, I'm proud to be joined by our session chair, Luca Cordaro.
Hello, Gerrit. How are you?
I'm
You're
more
still
than
alive.
ready
You're
for that
still
last
alive.
session. Very excited, as you can tell.
Okay, so thank you very much, dear colleagues, for being here until the last session. It's a pleasure for me to introduce the two speakers. Before I introduce you a little bit the topic, two speakers here are very brilliant guys. I had the chance to know them better during the preparation of this session. Henri Hagenmüller, he is a partner at Boston Consulting. You would ask yourself, why is he here? Because he has been consulting for several medtech big companies, in not only in the field of dentistry, but in the field of healthcare, generally speaking. And he has performed market research for these companies as well. So he has been a strategical consultant on one side, but he also knows the market very well. And he will show us some very interesting figures. The other speaker is Stefan Wolfart. He became professor in prosthodontics in Aachen very young, and for sure he's not one of those old professors with a closed mind. He's for sure an open-minded guy, and you will see he's also a great clinician. And we will try to have a look at this topic from 2 points of view. The clinician and the patient from one side, and the industry and the business from the other side. And as dentists, everything we do comes with something that we buy from the industry, most of it. And you see I have some gray hairs. I have been practicing for more than 35 years, and after a while, my mantra became, if ain't broke it, don't fix it. That this is how the US guys will say, or in Europe, never change a winning team. Once you have a method in your hands that work, for me, it is very difficult to find someone who would convince me to change it. And this, of course, is not the best approach to look at innovations. But then when we have to have a look at the development of new technology, you will see this graph in the presentation several times. This is the curve of development of a product. And you see that when it comes to the product spread around the market, you have different responses. You have the enthusiasts, the early adopters, the late adopters, and the laggards. And this has to do not only with the spread of the device within the market, but it has also to do with the development of the device, as we will see. So why are dentists skeptical sometimes? Well, because they have bad experiences with other new products that they have tried. Sometimes we all have experienced that. Something comes in our office, and then at the end of the story, it does not work. Then they're skeptical because they have had a bad relationship with the industry. And sometimes they're also skeptical because they don't believe to the people that are on stage in these meetings, in these congresses. They have the feeling that they might be driven more by the industry push or by the evidence than by what is really there. Okay? But of course, why are also the dentists enthusiasts of adopting new technologies? Well, of course, you get a better professional perspective, because the patient realizes that you're using something new. These new technologies many, many times can be used as a marketing device towards our patients. You feel that sometimes you could improve the workflow of your work. This means reducing time or making your workflow more efficient, both clinically and economically. And at the end of the story, you also have the feeling sometimes that you could deliver a better treatment overall. So this session will be all about relationship in between dentist and industry. That is something that we experience every day. Sometimes we don't step back a little bit to have a look at it from outside. We are into this relationship every day. And I think that what we will see this afternoon is, will really open our eyes. There are two very different perspectives. We are dentists, and they are the industry. Now, as dentists, we have an objective, that is to deliver treatment. And the objective of the industry is to sell devices, okay? So you see that it would not be easy to bring these two different objectives together. If you look at this graph here, this is the typical evolution of a drug. This is something that comes from a book of economics, nothing to do with dentistry, okay? You see that there is a rising part of the curve, then there is a plateau, and then the diffusion or the use of the drug goes down. Because other drugs are coming up, other treatment opportunities are coming up. But what happens in the medical device market, and also this slide that I'm showing you comes from a book of economics, is a little bit different. Because what is happening in the medical device market is that the companies, to keep up the level of selling, they come up with new products all the time, so that the plateau is always there. Sometimes these new products are needed, are helpful. Sometimes they are only a way for the companies to continue a decent selling volume. And one other big issue when it comes to the relationship of the dentist with the industry is that, as you know, for instance, in implant dentistry, we are very happy of having nice long-term results of our restoration of our implants. But if you carefully look at what is happening, these long-term reports are related to devices that you cannot even buy anymore. There is little in terms of long-term results of the new device that are introduced in the market. This is very important. But the last part of my, I hope, short presentation is that how you read the data that are there is very important in the message that you are delivering. So it's very easy to have a bias if you're not really a fair speaker. I will show you three graphs. This is the evolution of CT scans. We all know that CT scans have improved diagnostic capacities in all areas of medicine. You see, this is the 25-year evolution of CT scans in the UK. The number has increased dramatically. If you see this on the top graph, in the lower graph, you see in blue the number of exams, and in red, the radiation exposure. So you see that the number of exams has increased dramatically, but the radiation exposure is stable. Why is that? Because the industry there has helped a lot. The industry has produced machines that need less radiation exposure. And this, we would say, it's a great technological achievement. If you look at this graph from the same paper, you see in red the enormous increase in computer tomography, the decrease in standard radiography in pink, but you see that the radiation dose is there. But this is the behavior in the UK. If you look in the same period at what happened in the US, you see that it's a complete different story. The level of standard radiology is stable. The number of CT scans is peaking. But the most important thing here is that the radiation exposure is 5 times. So here, what happened is that the influence of technological innovation has produced something that might be a problem for the patients. So with this, I pass the word to the two speakers. They would tell us what they see as the trends in digitalizations in dentistry and in implant dentistry. And we give the word to Henri before he would give the industry perspective on that. Thank you, Henri.
Thanks a lot, Luca. Thanks, Gerrit, for the kind invitation and introductions. It's really a pleasure to be on stage with you today. And what we see is that the digitalization of industry, of dentistry is accelerating very, very fast. And there is three main drivers for that. So on the one hand, we see the consolidation of practices. And that these larger practices and dental chains, they put more emphasis on the optimization of workflows, both internally in their practice, but also in the external communication and exchange with labs. And furthermore, the large practices and dental chains, they have the scale and patient volume to be able also to invest into that new technology very nicely. A second important driver is that patients often prefer the new technology in terms of comfort level during the treatment. They enjoy the involvement and engagement during the treatment pathway, and they trust also into a modern-looking clinic, let's put it this way, and a dentist who is applying modern technology. The same is true also for employees who are in favor of joining clinics which use modern technology and seem to be future-ready. Then beyond that, we have general dentists performing more and more specialized treatments, mainly the aligners, but also implants. And for both of these treatments, the general dentists are enabled to do so by modern technology.
So I think you need a slide.
Yeah, exactly. So what you see here is from a little survey that we conducted with general dentists in the US and in Europe, and we asked them which procedures would your clinic expect to introduce or do more of over the next 2 years. And you see more than half of the general dentists answer, we will do more, or we will introduce aligners in our practice, or we will do more of or introduce doing implants in our practice. And as I said before, to enable them to do so, new technology helps them. That's another driver. So when we look into how the ecosystem in dentistry will evolve, we strongly believe that new technologies will shape that. Up to the 2000s, the dentistry ecosystem looked a bit like that. You had many single or small group practices. Regarding the implant process, you used physical impressions, you used handmade prostheses, and the lab landscape was very, very fragmented, with very small, close-by dental labs. What we see now today is that there are larger dental chains forming, that the implant process is more and more digitalized already by the use of iOS and chair-side or non-chair-side CAD/CAM, and the dental labs continue to consolidate already, and the number of labs goes down. And when we look into the future, we expect that even larger international dental chains will be forming, digital guided surgery will become a new standard, and labs will form more of a hub and spoke model where you have few big labs and small and many small labs serving the dentists close by. That development will continue into more direct-to-consumer models, into 3D printing, chair-side maybe, and even a further consolidation of labs. So all of these things will help to increase the efficiency of the overall process. But efficiency is not all that we should look at. It should be always in balance with the outcome that matters to patient. And therefore, I'm a big fan of the value-based healthcare model, which is a concept which is more and more applied in the procurement of medical technology. And it tries to, on the one hand, make sure whenever new technology is brought to the market, it helps to improve the outcome that matters to patient, and at the same time lowers the cost of delivering that care. And that concept, I guess, is very important for us to keep in mind. And also over the next hour, I will always refer back to that concept and see when we talk about new technology, if they actually are going into the right direction from a value-based healthcare perspective or not.
Okay. So this technology is here to stay. At least this is what comes out from your view. But let's see what Stefan has to show from the clinical or patient perspective.
Dear Luca, my perspective is more the perspective of the dentists when we really want to change our practice from conventional to digital. And the question is, where should we start there? And we have different fields where we can start. We can start with the virtual planning, with the surgical guide, with implant placement, impression taking, relationship record, and the monolithic restoration, which we can make chairside in our office. On the other hand, we have the dental technician, but the dental technician is already digital because otherwise he could not do zirconia crowns and so on. So for him, this question does not arise. So it's more our point where we have to go through. And you already mentioned it, what is with the innovation circle? And this is a picture of myself when I was graduated from dental school. It's a little bit away. And when I was so young, I want to check out every new development at the moment when they are on the market. Now, 20 years later, I have a lot of more experience. And so when I have a system which is working in my hand, I want to keep the system. And I think twice before I change it. So if I take your innovation circle, I would be on this side, I would be on the innovator side when I was young. And today, perhaps, I'm on the early maturity side. So it's also depending on your age and how long you have your practice when you are changing from analog to digital, in my eyes. And for me, today, it's very important that we have to think about different questions before we change. The first thing is, you already mentioned that we need clinical studies. And the workflow should be simpler and faster, that's important. We should improve our quality, that's important. The patient quality, comfort should be increased. And also from the economic side, it should be an advantage for us before I want to change my system, which I already have. So, and now, let's come to the live poll.
It has come to the live poll, and that is where our live audience in the room is invited to participate. So I invite you to pull out your mobile phone, direct your mobile browser to app.eao.org, which is probably a mobile website you have open all the time, because that is how all the sessions here are interactive. And right there, we will launch 4 different polling questions for you. Scroll all the way to the bottom of your screen once you hit the button Interaction. So you open up the app, you click on Interaction, and right now, Josephine, it still says waiting for the question, but I already see it on the screen. The question is, I use a CBCT scan for planning implant surgery, and you have 4 options to answer. Do you say, yes, I always do that. I do that most of the time. Maybe you do that rarely, or maybe you do that never because it doesn't apply to your situation. Trying to make sure that I can copy the process with you as well. And I'll give you a few seconds to find your way into the mobile website, to hit the interaction button, and then cast your votes. There, now I see it. Thank you, Josephine. And hopefully you see it as well. And there we see the results. That's funny. I'm one step behind.
So it's clear here.
It's clear that half of this room voting is already using it always. And if we add up 1 and 2, it's over 80%.
Yeah.
Let's go to the second question. We have 4 questions in store for you. Second question is, I use guided implant surgery with a CT scan and a navigation template always in my surgeries. I guess it depends if you do or support surgeries. Most of the time, rarely or never. Same answering options.
We include in this question also the navigation technology. It's not only the stents.
Exactly. We give you a few seconds to make your way into the application to cast your vote. And then once Josephine sees that we have a significant number of the room ready, we get the results. Thank you, Josephine. Hey, that is a whole different picture. I can imagine that's also perhaps because quite a few people in the room are not that close to surgery, perhaps?
Oh, I think that it has to do with the development of the technique. I mean, the mature dentists have started with freehand surgery.
And
so there
as
is...
Stefan explained, they
Yeah.
might not be ready to jump on
No,
the curve.
it's not that they might not be ready. It's also that they might feel that it's not needed. So this is why. But this is the discussion we will have on that will clear up this.
So you in the room are feeding our discussion here on stage. So let's go to question number 3. I use intraoral optical scanner for implant restorations. You are familiar with the answering options now. Do you do that always? Do you do that most of the time? Do you do that rarely? Or never because it doesn't apply to you? Or because you don't want to, you don't like it? I don't know. Could be many reasons why that is. We don't ask you that yet. Let's see if we have collected enough results. Yes, there it is. Ooh, that's a little bit all over the board, Luca. You see.
Well, this is I would say, a newer approach compared to guided surgery. So of course the diffusion is different. But again, it looks like only 16%, that is very little, of the audience will never use an intraoral scanner or has never used it. This does not mean they will not use it in the future.
I like your glass half full approach on interpreting the results. Let's go to the fourth and last question. How do you produce your restorations? Do you do that with chairside milling? Do you do that with an in-office dental technician? Or perhaps with a small dental laboratory in your hometown? Or do you send it off to industrial milling center or a laboratory chains? In this case, unfortunately, you do not have the option, it does not apply to me. So if you're not involved in that decision, maybe you could answer for the practice that you work at or for, and in that way we can collect some insight from our audience here in the room. And there we see the results. And here we see, I think, Luca, that most people, 65%, do offshore that procedure, but still locally.
Yes, this calls for the fact that there is a very little diffusion of chairside milling, at least in this room. We will hear from Henri what his data are.
I see Henri nodding and taking notes. He's like, okay, I'll tap into that.
And
good.
That most of the people still use the local labs. And I think that this is something very good, because we have to keep alive the category of dental technicians, because I'm sure that Stefan will say that we will anyhow need a dental technician in our life. So this cannot go to an industrial production per se 100% of the cases, at least now.
Thank you for your participation. I think we move on based on this data.
Yes. Yeah, it's very funny or very, very interesting that that 30% does not use guided surgery. They stay with something which we see here, which is freehand implant placement with a normal drilling template. And now the question is, should we leave this freehand implant placement with a simple drilling template and go to a digital treatment planning? And for me also, the most important point is, what is our patient telling us? And therefore, I have a video with me where we can listen to him.
Wir haben ja bei Ihnen im Unterkiefer mehrere Implantate gesetzt, um darauf festen Zahnersatz zu machen. Und zur Aufklärung der Operation habe ich erstmal Ihre Zähne gescannt. Wir haben dann eine digitale Aufstellung gemacht, also ohne Modell, und haben sie dann an einem dreidimensionalen Röntgenbild, wo auch die Implantate eingeblendet waren, aufgeklärt. Wie gut fühlten Sie sich denn auf die Operation vorbereitet und aufgeklärt nach dieser Operation?
Das hat mir sehr stark geholfen, dass Sie gesagt hatten, hier anhand der Bilder, hier haben wir noch so und so viel Platz bis zum Nerv. Also das war im Grunde eigentlich wie bei einem Archäologen, der genau sagen kann, jetzt kommt diese Schicht. Also ich wusste es ganz genau, auch bedingt durch Ihre Aufklärung. Da wird nichts schief laufen. Diese Aufklärung hatte mir schon sehr, sehr viel Entspannung mitgegeben.
Okay, sehr schön. Sage ich mal, so eine Hightech-Aufklärung, wie wir es jetzt gemacht haben, schafft es zusätzlich Vertrauen für Sie?
Definitiv. Ja. Also ich muss das sagen, nachdem ich das genau sehen konnte, auch mit der Schablone, also wirklich, das ist ja so ähnlich, denke ich mal, wie bei einem Flugzeug. Also man sitzt als Passagier und man gibt sich also in die Hände des Piloten. Und man geht fest davon aus, dass der wohl sein Handwerk beherrschen kann.
Jetzt, also die 3D-Analyse hätte es noch nicht gegeben. Ich hätte eben nur so ein Röntgenbild, wie Sie es jetzt sehen, also in einer Dimension gehabt, ja, und hätte Sie daran und an Skizzen aufgeklärt. Rein hypothetisch jetzt, glauben Sie, das wäre genauso gut gegangen?
Die Sachen, die wir jetzt vorher gemacht haben, die haben natürlich zusätzlich zu meiner Beruhigung beigetragen. Ich muss aber fairerweise sagen, ich hätte auch sonst das Vertrauen zu ihm gehabt, zu sagen, der macht das schon ordentlich. Ja.
I think it's very interesting what he said to us, because he said, okay, this kind of CBCT scan and the navigation template gives him additional confidence, because he knew exactly what will happen afterwards. And this gave him relaxation. And on the other hand, he told us that if I would have done it in a simple way, it would be also fine for him, because he has confidence in my person, and that's the most important point. That's more important than the other thing. So when we go to literature and look what the literature is telling us about this, then it's very simple. Generally, the patient prefer computer-based technologies, also in this case. They are always impressed from that. However, if we look if we have any difference in the intra and post-operative discomfort, there is no difference between these two treatment options. So it's something which is more between you and the patient. When we see the clinical perspective, for me it's like this. I make a CBCT scan, I make an intraoral scan on one day, we match both together, and then we have to make a digital tool set up, which I can do directly if it's only one or two teeth, and or I can use the formal initial situation which we have had, or if the situation is more complex, I send it to the dental lab. And then I plan the implants, and this is for me very important, because when I make my informed consent for the patient, I really can show him how the distance to the nerve is and how the risk is to injure this nerve, for example. And on the other hand, I can see what kind of bone augmentation I have to do. Is this a case which I can do by myself, or do I need a specialist for this operation? And that's something I can see, and I can plan it in a perfect way. And then we place the implant, and for me, the advantage of these systems is that we can make really a precise informed consent to our patient. That the operative measure, as I said already, are predictable. That we have a faster and safer implant placement, at least in my hand. And very, very important, we have optimal position of the implants. And that will help me also to make a much more easy prosthetic treatment afterwards. And the disadvantage is clear. It takes a longer planning phase, and on the other hand, we have higher costs. So here you see the implants which are completely in the right position where we planned it. And the next step is that we could go from a static to a dynamic computer-aided implant surgery. And there, I have a question for Henri afterwards, because this Forerunner model, which we have used here, cost 33,000 euro. That's a lot of money for me. And after 8 years, there's a new one with a better camera and so on. It costs 34,000 euros. So where's my return on investment in these cases? That's something perhaps Henri can answer for me. And here you see how we work with this system, and there's a reviewer who's checking all the accuracy of these systems. And the review showed us that this dynamic computer system has a very good accuracy. It's around 4 degrees of the implant, which is different, and it's 1 millimeter position error, perhaps, at the entry point of the implant placement. Different dynamic systems have no difference between these systems, and if we compare the dynamic system with the static system, which you have seen before, then there's a very, very small difference between. However, if we compare the dynamic system with a freehand implant placement, there's really a large difference. If this difference is clinically relevant, that we can discuss afterwards. So my question was, should we leave freehand implant placement with a drilling template? And I would say, yes, we should leave it. We should use navigated implant placement, and this could be static or dynamic. That's not important for me. However, the disadvantage is we have higher costs, and it's more time-consuming in the planning phase.
I need to make a comment on this. As an old-style man, I think that to perform this technique, that of course has several advantages, you need to be trained to do the same surgery also freehand. We cannot have youngsters that go into the field trained only to do guided surgery without the capacity of placing an implant without the aid, because this calls for a series of issues that I think would not be good for the practitioner. I don't know if you agree with that.
Yes, it's a very important comment, I think. I would answer you, I believe that every surgeon should be able to make a freehand implant placement, because, as you know, sometimes the CBCT scan is not right, or sometimes the template is not working fine. So you need a plan B sometimes. And therefore, you're completely right. You should know how it works. But that does not mean that we should not use these new technologies.
Of course. Thank you. I think now it's time for the business guy, excuse me for that, to show us his perspective on this topic of guided surgery. Henri, what is the market saying here?
No, perfect, Luca. Happy to do so. First, Stefan, I guess it's very exciting to see what you can already do in dentistry with guided surgery. So let me maybe from a business or industry perspective more refer to another field in medicine where guided surgery is already much more advanced or longer in the market than in dentistry, which is orthopedics. And actually in orthopedics, there are also the following new technologies, or not so new technologies anymore, which help kind of the adoption of that way to operate. So on the one hand, you have the 3D virtual planning and the patient-specific instrument ordering, right? Maybe we can even leave the slide up if that's good. Exactly, so this is the left-hand column, right, which is introduced and heavily used, and part of that already, Stefan, you were already referring to also in dentistry right now. Then the second important puzzle piece is the navigation, which also is, of course, heavily used in joint replacement today, a bit similar as you also showed it now in dentistry. And the third step, I guess, is not so common yet in dentistry, is robotics, which in orthopedics is already the next step, that robots conduct the surgery and you control them remotely via a computer. So let's maybe see a few years back also how that was adapted in orthopedics over the last years. Just some example numbers here. On the left-hand side, again, you have 3D virtual planning and the patient-specific instrument ordering, referring to numbers from Stryker and Wright for the shoulder space. And you saw when they introduced their new planning software in 2017, within only 1.5 years, 40% of all of their customers adopted to that new planning software, probably because they liked it so much. Second, the navigation. Here an example from knee procedures over many years in Australia. You just see over many years there has always been a very fast growth of 24% growth per annum of adoption of this navigation technique. And even in robotics, more recently, we see strong growth of uptake in robotic surgery in orthopedics. So just want to show that as a bit of a reference maybe. And I don't know, dentistry might go into the right direction. We will see. As I showed you in the beginning, in my introduction, I would always like to look at things also from this value-based healthcare angle. So to which extent...
That's very useful.
To which extent is this new technology really helping to balance that equation? So on the upper part of that equation, so the health outcomes that matter to patient, at least in orthopedics, the introduction of these new technologies, they have shown that they improve clinical outcomes, that they shorten the surgery time, which also matters to the patient a lot, and they even increase the access to care for patients because maybe even more doctors might be able and confident to conduct these surgeries, which is all very positive and matters to patient. On the cost side, again, surgery time is shortened. That, of course, also reduces the cost in the hospital, as for dentistry in your clinic. The inventory is reduced, which is in orthopedics
very important in orthopedics.
Yes. Large set of instruments and of implants on the shelf, and because you can do the planning digitally, order just specifically for that patient, your inventory shrinks a lot, which helps you also save money. You mentioned parts of that already, Stefan. There is a high investment related to it in orthopedics, specifically in the robotics space, right? High upfront cost, large spaces required. That one has to keep in mind. But overall, I guess these are the elements that influence the value-based healthcare view in orthopedics.
So if I may interrupt you just 1 second, these new technologies are picking up in many medical fields. They have for sure good results for the patients and for the surgeons, but they call for a huge economical investment.
Yeah.
So this is something that we have to keep in mind when we plan our professional life, or at least for the youngsters that have to do that. So thank you very much. Thank you very much. Now, I think that the next topic that we are addressing here is the introduction of intraoral scanners. And I think this time is Henri who will give the first answer.
Yeah.
And then we see what Stefan has to say about this.
We may move to the stage for that.
Yeah, of course.
Maybe we can have the slide up again. So in intraoral scanning, we see, let's first look at our starting point and how much adoption we already see in the market. So this data is from a study that we conducted across many dentists that we surveyed in Europe. It actually is 18 months ago, while of course our latest results on the screen before were just some minutes old. From this study, with a high sample number, we saw 35% of the practices already have an iOS in place, and 37% of the practices are planning or considering to buy an iOS in the next year. So we already have for sure a very significant share of adoption, and I guess the latest numbers here, I guess you had about 30% of you who always use iOS, another 30% of you who most of the time use iOS. I guess we see that the adoption has already further increased, so that's the first fact. Second, when we think about where is the market, for us it's clearly that the iOS market is at this tipping point of mass adoption. But where does that come from? On the one hand, the modularization. So that means formally, the iOS has been sold together with a chairside milling machine for more than 100,000 euros. Now it's debundled. You can buy your iOS standalone. That reduces cost. Costs go down to, as levels down to 10,000 euros for an iOS. And there are flexible financing models like leasing and so on. That all helps the adoption. The technology is advancing. Scans get more accurate. They get faster. They can detect the color of the teeth and so on. That also drives the adoption, as well as the better, easier integration in your digital workflow and the communication with the downstream lab. The boomer generation of dentists is retiring, as in every profession. That means a generation with many dentists is handing over their practices to younger dentists right now in the next years. And that, of course, also will drive further adoption for the ones who did not change to iOS yet. And the dentist consolidation, I mentioned that in the intro, gives many practices the scale to invest as well. Overall, what we see on the right-hand side is a bit that curve that also Luca and Stefan were already referring to. And you see that we are close to that steepest point of iOS adoption. Probably we are a bit further than shown on that graph here, which is data up to 2020. And you also see from that data that the US is a bit ahead of Europe in terms of adoption. That's where we are right now. But we also ask the doctors, why do you use an iOS? What's the benefits you are using, you have from using it? And we see the number one reason, the number one benefit they are seeing is it improves the quality and the efficacy of the treatment. The second most named benefit was it improves the patient experience during the impression, especially with patients with gag reflex. And the third most called out benefit was that it reduces the overall treatment timeline for the patient, because the communication and the sending of the impression to the lab, of course, becomes much, much faster. So there are several reasons, pro dentist, pro patient, that people see from iOS. We also ask the ones who did decide against an iOS, why do you not buy an iOS, right? So the 14% of dentists who answered, we considered but decided against iOS. On the right-hand side, you see what was the reason for that. And the dominant reason for it was the cost of the hardware was too high. The second most called out reason was my volume is not big enough to justify that cost, which is somehow related also to the cost topic. And the third most called out reason was the accuracy of the scan is not as good as with a physical impression. So when we now check the investment into iOS again against our value-based healthcare concept, let us focus on the efficiency and the business case behind iOS first, so the lower part of that equation. So typically, when you look into a break-even calculation, you can see the picture here on the top. You upfront invest 10 to 20,000 euros into your iOS, and you might save time. You might save money over time the more you use it. And the business case behind it is that you save time during the impression, that you are faster with the iOS than with a physical impression, and that time saving will pay off the upfront investment. That's the idea behind it. How fast you reach the break even, of course, will depend on the upfront cost you pay for your iOS. It depends on how much is your true time saving of an iOS scan versus the physical impression, and what's the cost you pay per hour for your dentist or yourself or your assistant also involved in that procedure. And then, of course, it's the number of procedures which also depend on how steep your break-even curve is. There is one watch out, because this business case depends on realization of efficiencies and cost savings in the end. So you only realize that profit, which is the business case behind the iOS, if you do more patients in the same time, or if you do the same volume of patients just with less staff. Else, the profit only appears on paper. Yeah?
So again, Henny, the industry is providing us with a new device, a new approach that for sure is a very nice thing to the dentist and to the patient, but that calls for a different business model, needs high volume of cases to be treated to make it worth from an economical point of view. This is what the message is.
Yeah, it's from the pure dentist investment perspective, as you pointed it out, Stefan, before on surgery, right? Can I really spend that money? Is it worth it? I guess that is exactly more of a business angle one needs to take, indeed. Okay. And of course, there are secondary benefits, which are always very difficult to quantify. The marketing impact we discussed, that it might be easier to acquire new patients, to recruit staff into your modern clinic. Maybe you're doing the lab also a favor because they don't have to scan it. So that's a bit the idea, indeed. Yeah.
Okay.
And then on the outcome side, the matter to patient, we saw that in some data before. So suppliers and many dentists claim that the optical scan improves the quality of the treatment. The patients appreciate the better experience during the impression, and they also appreciate the faster procedure time. So if I sum that up, I guess iOS is reaching mass adoption. For me, there is no question around it. 40%, maybe in this room already more dentists are using iOS. 60% of these non-users are considering to buy an iOS just in the next year, and a saturation of 95% is what the industry in general expects. And that's driven by the better patient experience, faster, easier integration into the workflows, and an uptake of this aligner and implant dentistry by general dentists, as I said in the very beginning.
Okay, thank you. I think these data are really highlighting to us. Thank you very much for delivering it. And now we see the dentist perspective from a clinical and patient point of view. Stefan, what do you have to say?
Henry, I'm a little bit afraid now because I have to reduce my stuff or work more. That's incredible. So perhaps I would like to stay with this type of impression making, which is very simple, and I have a plaster cast afterward. So should I stay or should I go? That is the question. And I think we should ask our patient again.
Diese 6 Implantate werden auf konventionelle Weise und mit einem digitalen Scan abgeformt werden. Und wir sind sehr gespannt, wie sich das für den Patienten anfühlt und welche der Behandlungen er angenehmer empfindet.
Und ich muss sagen, ich persönlich finde das eine tolle Sache, dass man eine dreidimensionale Struktur digital aufnehmen kann. Und das ist ja meist eine relativ genaue Vermessung. Also ich persönlich finde das eine sehr positive Entwicklung.
Wenn ich Ihnen sage, beides ist genau gleichwertig, Sie können sich aussuchen, was Sie wählen würden, was würden Sie von beiden wählen?
Also ich würde eigentlich immer die digitale Variante wählen, aus dem Grunde, weil man nicht so gerne Chemikalien im Mund hat.
Okay.
Ja, mit diesem Abdruck und so.
Ja.
Das ist jetzt auch nicht schlimm. Im Laufe des Prozederes bis heute oder so hat man ja schon Schlimmeres erlebt. Und da würde ich sagen, da würde ich das Digitale eigentlich immer vorziehen.
Okay. Häufig ist bei Patienten so, dass sie beschreiben, ich habe eigentlich Angst, dass das vielleicht wiederholt werden muss. Haben Sie sowas?
Mir geht es ja darum, dass das Endresultat gut ist.
Ja, genau.
Und dann ist man auf dem Weg dahin, glaube ich, ziemlich geduldig.
Ja, das ist ein ganz wichtiger Punkt. Ist es für Sie so, dass Sie sagen, okay, wenn da jemand solche Technik anwendet, dann stärkt es auch das Vertrauen oder hat es miteinander nichts zu tun?
Also ich würde mal sagen, dass das davon unberührt ist eigentlich, weil wenn ich mich in Ihre Hände begebe, vertraue ich Ihnen ja ohnehin vollständig. Ja, und insofern glaube ich, dass wir die richtige Wahl treffen und ich vertraue Ihnen ja auch als Experte auf dem Gebiet, dass Sie das alles 100%ig beherrschen. Von daher sehe ich da keinerlei Unterschied.
It's very interesting what this patient of mine is telling us. He tells us, I trust you as an expert. You have to choose the best possibility because my concern is not this impression or that impression. It's more, my concern is that the final restoration is perfect, yes? And if I have the choice, I would choose the digital one. And why? That's simple, that we have it already heard from Henri, and it's also in studies about patient-related outcome measures where we see optical impression is associated with better taste, less gag reflex, less pain and less discomfort. But what is our clinical perspective on that? Our clinical perspective is that if we have single crowns or short span FTPs, then we benefit from this digital workflow. So it's fine if we are doing single crowns or small bridges. However, if we are not talking about implants only, if we also have to integrate natural abutment teeth, then it's a completely different story because there are studies who show us the position of the margin of the abutment teeth is very important because if we have really deep margin, then they really say intraoral scanner is not recommended. So we need also for these cases a normal impression. And I want to show you this in a case of mine and where it took much longer with the digital way because I have to optical scan not only the scan bodies, which is very easy, but I have to scan also the teeth, and that's not so easy, as you can see here. This is a prepped tooth, and I use a normal medium retraction cord for that, and you can see here that we have really inadequate situation of the preparation margin. So I took out the retraction cord, put a large retraction cord in, and now you can see that now the preparation margin is really visible fine. However, it's a risk for gingiva retraction now with this retraction cord. And if you take these two scans and overlay it, then you can really see that there's a difference and that it's really important to have a perfect scan for perfect restoration. And that's really a dilemma in my eyes. And if we go to the edentulous jaw, there are also reviews which show us that in clinical studies, there's a sufficient accuracy in impression. However, if you're hearing most of the presenter, they always say, if I have a jaw without teeth and the restoration is only implant supported, I stay with a traditional impression. And for the optical impression, we have a accuracy error of around 150 microns that is at least equivalent to the conventional impression that is the result of this meta-analysis. And the most important factors why we have problems is the distance between the implants. The bigger the distance, the bigger the accuracy error. And the scan body design, the scan path, and very important, the experience of the dentist. These are the important factors for the accuracy if you are scanning the edentulous jaw with implants. Another thing which is difficult, if you have lost all the occlusal support, then you could not make such an easy maxillomandibular relationship record with a buccal scan. You have first to make some other steps which we have to think new. For example, here I leave the provisional restoration in the front and take it away for the molar region. We make a splint, and then I can take out the front provisional restoration, leave in the splint, and then I can make the final buccal scan. And so I can make also a relationship record in this very difficult case. But we have to think new ways here. So the question is, should we leave conventional impression procedure and plaster cast? I would say yes. For monolithic implant restoration, single crowns and short FDPs, we can do that. Perhaps for a combination of natural abutment teeth, it's difficult when the margin is subgingival. I have explained you that. And in my eyes, it's not worthwhile in the moment for the full arch restoration.
And Stefan, one question.
Yes.
If you have to go for a veneer or an inlay, I mean, not more on implants, but on teeth, what would you be your technique of choice?
Yeah, that's a complete different story, and therefore I would never say in the moment we need only optical scan, because when you prep an inlay or an onlays and you don't want to prep too much away, then sometimes you have structures which is not possible for a milling machine to mill. And therefore, it's much easier to have a normal impression and make a pressed inlay or pressed onlay, and this will fit perfectly. So, or also a veneer is often much more easy if you do it in a conventional way.
Okay. So again, it's a great tool. Dentists like it, patients like it, but we cannot throw the old techniques away.
No, I would never do that.
Thank you very much. So the next topic we are looking at seems not deeply involved in our personal business plan, but at the end of the story it is, because what we're going to talk about is about the manufacturing of our prosthesis. If this is going to be made completely digital in the future or in other mixed methods. So in this respect, let's hear what Henri tells us about the market tendency.
Thank you, Luca.
Thank you.
So in the production of prosthesis, we see three main trends. So the first trend, again, is consolidation. So the four types of lab on the left-hand side is what we see in the market today. You are very well aware of that. We asked you about it in the entry poll. The in-house practice labs, which are really very common in Germany, less so in other countries. Then the small and medium labs, which are very close by in your hometown. I guess from the poll in the earlier, we saw that most of you are working with those labs to date. The large but still local labs, which already have industrialized the production to a certain extent, but are still close by or somehow close by. And then there are more offshore labs or import labs, where the production is done far away from you, let's say from a European perspective in Asia, and then they are coming back to Europe also then for the patient treatment in the end. That's the current situation, and what is going to happen is that more of these labs are consolidating. You see that on the very right-hand side of that chart, and they are forming international lab networks, which is to a large extent only also driven by private equity funds who are owning these labs and building larger and larger networks. The dental service organizations or dental chains are beginning to have their own labs and make them big as well, and they have the scale and the investment power to roll up these networks very, very quickly. That's the first big trend. The second big trend is the new materials that are allowing for the automation. So here, what you see is the different material used for the crowns and bridges. And zirconia is the big winner together with Emax. So zirconia already has a very, very large share of the crown material, but we expect over the next 4 to 5 years that even goes up to 40%. Emax similarly up to 15% of the share. And PFM and all other metals are decreasing rapidly in their share. It's important to note what drives zirconia uptake. It is for sure the ability to process it in a very automated way, which also eliminates the labor work behind that and therefore makes it very efficient, very cost efficient as well, which is of course in favor of the investors behind it, and it drives down the cost at the lower part of that value-based healthcare equation. The third trend, chairside milling. So let me look into two different geographies here. So on the left-hand side, the US, on the right-hand side, Europe. So in the US, the adoption of chairside milling is happening much faster than in Europe. And what you see on this chart is when dentists are asked why they would not use chairside milling. This is the reasons below, but actually the reservation against chairside milling in the US is further coming down. You see data from 19 to 21. Number one reason not to use chairside milling, it is too expensive. Number two, I prefer to work with my lab. Number three, it's a potential workflow disruption, meaning the dentist has to deal with the production of the crown then in the chairside milling machine and is distracted from the work directly with the patient. But you see, as said, the reservation against it in the US goes down. Therefore, the uptake of chairside milling is further continuing in the US. In Europe, we see a bit more reservation and a slower adaptation. Yeah? The data that we came across here and were surveying from people was that the adoption is up as high as 20%. I guess in the poll that we had before, there was a much lower share of people using chairside milling in this room. The hurdles for uptake we see in Europe are still a very high upfront investment. I mean, it can go down as low as 50,000 euros, but that's the lower end today. Still a significant workload for the dentist, and therefore this distraction from working with the patient. The aesthetic quality of the product for some is not good enough. For sure, it's becoming better as well, and it's used in the back teeth, but that's still a hurdle. And last, again, the rise of the dental chains, which of course have the volume which then they can consolidate and centralize regarding their production, and they might not be in favor of placing these assets, these chairside milling machines, in all of their many practices if they can bundle that together. So when we now look again into chairside milling from an economic perspective with the famous two sides of the coin, let's focus first again on, does it help from an economic perspective for you as a dentist? So what you see here is conceptual numbers and sizes, but the first column shows you the price per crown that you can make as a dentist. It depends very strongly on the country you are in. It can be as low as 50 euros, Italy, Spain. It can go up to 400 euros in Germany. But anyways, that is kind of the revenue you can make if you produce your own crown. Then there's the cost associated to it. And the biggest cost block is the depreciation of your chairside milling machine per crown. And that again depends a lot on certain factors. So it depends, of course, how much you pay up front for your chairside milling machine. It also depends on the utilization of your machine. Of course, the more crowns you make on your machine, the lower the share of the depreciation on the single crown. And it also depends on the operating lifetime of your machine in the practice. Then there's the material cost of the zirconia, which is very low, only a few euros per crown. And the third block is the labor cost of the dentist or the clinical assistant in handling that machine and that process, which also can be more or less depending on how familiar you are, how fast you are in processing. In the end, what we see is chairside milling for the dentist in the practice can be very profitable, but it depends on a very high utilization of the machine and a fast processing of the machine in your practice. From a perspective of does it improve the outcomes that matter to patients? Yeah? And the main reason for patients why they like it is it's the speed of the treatment. They have a same-day crown, which of course is very comfortable also in their process. But I let Stefan later on maybe talk more also about the more clinical aspects of the outcome that matters to patients. So in the end, what we see in the production of prosthesis, labs are forming larger networks driven by private equity, partly owned by dental chains. The future of chairside milling in Europe is still unclear. Yeah? Up to 20% adoption to date. In the US, it's picking up faster, but in Europe, it's not so clear where the future will bring us in chairside milling. And the small independent labs, they will have a hard time given that context. And that's all driven by the higher profitability of the consolidation and the automation. It is also driven by technical advancements, of course, of the CAD/CAM process, and also in some areas of Europe by the shortage of qualified lab personnel.
So Henning, it is clear that these technical innovations might be very useful, might be also economically meaningful, but we have to have a reaction. We have to change our business model, both at the dentist side and at the dental lab side.
Yeah, mainly the lab. I guess there was a lot of change going on in the dentist practice setup over the last years, also driven by the dental chains coming in. And I guess now a few years later, the same is happening now with the labs. And I guess they will do very good if they, of course, increase efficiencies, maintain high quality, the proximity and the service level to the dentist. And that's what they try to crack.
Yeah, but if you don't react in your organization to these technical innovation, at the end of the story, they will not be economically efficient and they will not be maybe a good choice for our patients. So we need not only to adopt these technologies, but we also have to think at our practices in a different way. Yeah. So let's see what Stefan has to say on prosthesis production, the clinician point of view. Thank you, Henry.
Henry, I'm again very afraid because you told me that the small lab, which I have 2 streets away from me, and I really love these persons who are working there, they will not be there anymore in a year or 2. It would be very hard for me. So therefore, we want to go through this question, should we leave this traditional dental laboratory and the dental technician as we have it today? And that would be not very nice in my eyes. And can we stay with chairside milling, for example, in a fully digital workflow? And from the perspective of the dentist, it's like this, that it has an advantage because we reduce production costs, it's time saving, and it fulfills the patient's idea of a modern treatment concept. We have already heard this from Henry. And the important point for me is, are these restorations which we are putting into the mouth of our patients are really good restorations which will have a good long-term outcome? And I'm very happy to present you this study from Bjarni Pétursson from 2021. And he compared monolithic lithium disilicate and zirconia restoration with veneered zirconia and lithium disilicate restoration. And to make the long story short, the chipping went down if you go for monolithic to 1% instead of 5%. However, we have another problem now because we have a loss of retention. And this loss of retention is not clear where it happens. And perhaps it could be also the adhesive bonding system which we have in these monolithic restorations, as you can see here. And sometimes some of these titanium bases are very conical and have not a very good height. And this may be a problem in these cases. And I show you a case of myself. It was a patient. I inserted this crown 2 years ago, and I don't know, 2 months ago, so she came with this situation, and she said, okay, the implants are out, the implants are still in, but the connection between the titanium base and the restoration was broken. The restoration was broken, and the adhesive bonding was gone. So we have redone this bridge, this cantilever bridge, with a new, different titanium base, which is not so conical, a little bit higher, but only a little bit higher. And I hope that this will work. But as Luca already said, with all these new materials, we have nearly never data over long term. And this study could be the first one who shows us that we may have problems with these things. So, however, on the other side, this digital workflow gives us new perspectives. And as you can see here, we have a situation, we scan the situation pre-operative, we take away the part where we make surgery, we place the implants, we place scan bodies on the implants, and then we can scan it very easily without touching the surgical area, and we have the position of the implants in our scanner. And then we can go for virtual design, as you can see here, and in the end, we end up with something which we can use for provisional restoration, or we can use it for final restoration. It's up to you. And here you see a provisional restoration, which is milled out of a telecut block. And however, it's up to you. Here it's a second stage surgery. We made this provisional. You see the very nice emergence profile which we get in this situation. However, you can do it as an immediate restoration, immediate loading, early loading, as you prefer, or you can use it also for final restoration. If it's perhaps in a non-aesthetic area, then it will work fine, I think. As you see here, you need not more than 1 or 2 hours for such a restoration. You mill it out of a block, and you fix it provisionally on a titanium base. You try it in, you look if the proximal contact and so on is fine. Then you make your sintering process, and you connect it definitively with a bonding system. In this case, we use multi-link hybrid abutment for this kind of restorations. So, and I want to show you a new perspective. This is one of my co-workers, Lukas Waltenberger, who invited this system, and we make a clinical study with this concept now. We call it safety crown. And it's very interesting because we try to make implant-retained crowns in the molar region or premolar region in only 3 appointments. And we have a definitive abutment which we produce before implant placement, and we use a temporary immediate restoration on it. And therefore, we have a one abutment, one time concept. We have a cast-free workflow in this case, and we have, in the end, a cemented restoration. So, how we do it in details. We have a diagnostic phase where we scan the situation, we make a CBCT scan, and we take the color of the neighbor teeth. That is important because we design the splint, and then we export the planned position of the implant to a new model, and we do construct on this model the definitive abutment with a margin which is about 1 millimeter supragingival. And then we have our zirconia abutment. And then we go to the second phase. We make surgery. We place the implant exactly at the position with the navigation tool, and then we have the abutment in place. We scan the abutment because the abutment is a little bit different in the clinical situation than on the model, and we get a provisional which we can put into the mouth on the same day. And after osseointegration, we only have to remove the provisional and we can put in the definite restoration. And this restoration, we make an adhesive bonding because we have a supragingival margin, then we have no problems with a very good adhesive bonding procedure. And here you see the final restoration in place. The point on the occlusal face, on the occlusal surface, will show you the point where you have to enter in the case of an emergency, so that you can go there, and then you know exactly there's a screw entrance below this, and you can screw out this restoration afterwards. So here you see the situation after insertion and 1 year in the follow-up situation, and it's very nice that the papilla grows a little bit into this. I have no idea why this happened, but it was nice that it happened. So these are the new concept, and Henri told us that perhaps we will lose our small labs in our hometown, and that's nothing which I really want to lose. And therefore, the partnership with my dental laboratory is, in my eyes, for me, very, very important also in these digital days. And therefore, I want to show you a not very complex case, but how we normally proceed in the digital days also with these cases. So we make our final impression digital, then the scan of the initial situation. We make the CBCT scan. We send everything to the dental technician. He is doing the tooth setup in digital. Then we make the implant planning, and the dental technician is doing the splint, the drilling template for us. Then we place the implants according to the template, and then we make our final optical scan. And now it's up to the dental laboratory to design the crowns. And in the aesthetic zone, we try to make microveneering, so we only take away the area where we have no occlusal contacts, and in this area we make a veneering for better aesthetic. However, if we are doing that, it's clear that we need at least a physical model and a traditional articulator, at least in our team. And we always use physical models in complex cases, in aesthetic cases, and especially for optimal bonding of the titanium base on the right position. In my eyes, the traditional articulator is not yet replaceable in these more complex situations. Here you see the final restoration, and here in the middle you can see how perfect the occlusion is matching with the situation in the articulator, so we can insert this restoration directly afterwards. So the question was, should we leave out traditional dental laboratories and dental technician? I would say yes, we can do that for monolithic single crowns and short span FDPs, implant retained if we want. We should not do it for aesthetic demanding restorations, and we should not do it for long span FDPs or full arch restorations in my eyes.
So at the end of the story, we have looked at the three main areas where digitalization is happening in our daily practice. Let's see, Henri, to sum up what we have seen.
And Luca, if I may, maybe in this sum up, you can also answer a question from the audience, which I think is quite clever. It reads, will a clever patient choose and stay in a below average dentistry clinic because they have new technological instruments? I think that fits nice in your wrap up.
Yeah. I guess, first to your question, Luca, first. I guess when I think about these new technologies, I mean, in my heart, I am an engineer by training. And I love technology innovation, okay? And I guess digital can bear very big values for us. On the one hand, it can help to support the doctor during the procedures. It helps also to involve and to engage the patient throughout the process. And it also helps you to connect to other stakeholders in the process, the lab, other specialists, in no time around the globe. I guess, therefore, digitalization can be of big value. Second, as I said, we need to get this value-based healthcare equation right. So must never look only at the efficiencies in a system, but in the focus, it always needs to be that the outcome that matters to patient is improved. If that comes with efficiency gains, I guess that's the ultimate goal, actually. And last, I would say, actually, the adoption of digital technologies in many areas is already happening, and there is no way back. That might be the case in iOS and in CAD/CAM procedures. I mean, in iOS, I guess we had 60% in the room who use iOS always or most of the time, which is already very large share here. Then on guided surgery, I referred to the fast pickup in orthopedics, and I can imagine that similarly also in dentistry, that will pick up fast. I guess in the room we had
actually that has not been the case so far, because guided implant dentistry has been introduced at least 15 years ago, and still you see it's not picking up too much. But please.
We had 28% in the audience who said guided surgery, right, is what they always or most of the time are using. So at least like we're coming to levels which are high. So I believe still in the future, and I also believe in the clinical evidence of it. And third, when we talk about the production, specifically chairside milling, that's what I also mentioned before. There I'm not so sure what the future will be in Europe. Only, I guess it was 4% here in the room use chairside milling. I believe in the centralization of labs to a large extent. That doesn't mean you don't have your lab technician anymore. It's rather a question, where does he or she sit? Does he sit like next door or in the same street, or maybe further away? But for sure they are needed. I guess that's still also which we'll see in the future. To the question from the audience, yes, I would say the number one focus of patients is always the clinical outcome and the trust in the doctor, and that they will choose. It will be very difficult for them to choose up front. But of course, there is a spread of word, of course, where you will go, and I guess they will not focus on the latest technology, but on the best reputation. There are, of course, situations and countries where you pay a lot out of pocket and where the insurances don't cover all of the treatments. And then you will see also that many patients just need to go where the costs are not the highest also. But in the end, of course, I fully would say patients choose more for outcome than for efficiencies.
But you know, when it comes to dental lab, consolidations of dental labs, and the fear of Stefan not to have his dental technician close by, the thing is that this digitalization model is shrinking the number of people needed to produce the things. And so probably it would be difficult for them to keep up a decent economical situation by only doing a small part of the big work. So I think that I see your point, but I also see Stefan's steer in a lot of pressure put into these laboratories.
Yeah, I guess a lot what the small labs do today, a large share of that volume will move away. As you said, there might be something remaining, but maybe not as much as today, I would expect.
Let's hope they can survive to this. Anyhow. What is your point of view, Stefan?
Yeah, we'll come back to my first slide. And I want to bring you a last patient to the audience now. It's a medical doctor. He's 70 years old, and he would like to chew with fixed teeth for the rest of his life. And he said, "Consider my age." And this guy, we could make a really full digital workflow, and I want to share this with you. So for me also, the patient-oriented therapy decision is always very important. So in his case, it was clear that we only have to restore the upper jaw and that he will not accept a sinus augmentation because it's too invasive for him. So the first thing is I take out the teeth which we could not remain, and then we make a provisional to correct the vertical height, and we check, we change a little bit the lower front teeth, and then we go for the implant treatment without sinus augmentation, and we go for a monolithic restoration with a buccal cutback or microveneering in his case. And again, I want to talk with the patient about this whole digital workflow. What is the perspective of this patient about this workflow? And let's listen again to a patient.
Also Herr Graf, wir haben bei Ihnen ja, haben die Backenzähne gefehlt praktisch, und wir haben daraufhin jetzt dort Implantate, Kronen und Brücken gemacht. Und wir haben das eben mit einer dreidimensionalen Planung gemacht und dann auch, wir nennen das navigierte Implantation, sodass wir die Implantate wirklich genau an die richtige Stelle setzen konnten. Und anschließend dann das Ganze mit einem digitalen Scan abgeformt, also nicht wie normalerweise mit einem Abformlöffel oder so, mit Chemikalien, mit Materialien im Mund, sondern mit einem Scankopf abgescannt. Und anschließend sind auch die ganzen Restaurationen mit einem CAD-CAM-Prozess hergestellt worden, also nicht mehr mit den klassischen zahntechnischen Methoden. Und einige der Dinge haben Sie bemerkt, andere Dinge haben Sie praktisch nicht mitbekommen, weil die im zahntechnischen Labor passiert sind. Und mich würde jetzt einfach interessieren, wie zufrieden sind Sie denn jetzt mit der Arbeit, die wir jetzt eingegliedert haben und die Sie jetzt seit ungefähr einem halben Jahr im Mund haben?
Die Frage kann ich nur beantworten, sehr zufrieden. Ich habe keine negativen Einflüsse. Ich kann gut essen und kann gut schmecken und kann gut sprechen.
Okay, super.
Die Digitalisierung ist mir sehr entgegengekommen, weil ich sehr empfindlich bin im hinteren Rachenraum.
Okay.
Und dass die moderne Technik was Besseres herausbringt, zumal ich ja diese Probleme habe mit dem Löffel. Diese Brechreiz sind dann immer.
Okay.
Deshalb kommt mir das sehr entgegen.
Okay.
Ich bin eigentlich mit allem zufrieden. Ich würde gerne das nochmal machen lassen.
So his last sentence was, I would love to have this done again. And this was a big compliment, I think, for this digital workflow which we have done, and perhaps also for the patient-related planning which we have done.
But also for the dentist, I have to say.
I'm not sure if this is the most important point here. No, but to show you the X-ray before and after, we have brought the level of invasiveness to a point which he can accept and which is fine for him. We have used the digital workflow, and that was a lot of comfort for him in the treatment. We have fulfilled his aesthetic needs which he have had, and until now we have had fulfilled the long-term stability of the restoration. It's now 5 years in his mouth. And on the other hand, with this cantilever bridge, we have fulfilled his functional needs, and so he is very happy with the situation. So that was a patient, and now let's come to my final conclusion. That was really not simple to bring it on in 3 bullet points, but I would say computer-aided implant surgery, static or navigated, it's not important, is a must-have in our toolbox. It's an important step in my hand for more predictable surgical results. iOS is nice to have. The patients love it, and you have new clinical perspectives with it. However, everything which you want to do as a dentist, you can do also with a conventional impression. You can take your conventional impression and you can digitalize it in your dental lab. So it's nothing which you must have in my eyes. And the production workflow for restoration, in my eyes, it's an individual decision. It's dependent on your office setting, of the aesthetic demands of your patient, and so on. Thank you very much.
Thank you. Thank you, Henri. We are not done yet. Now the ball passes to your side. You have to answer to this live poll.
Well, you have to. We invite you. We still have a nice room of an audience. So let's, I think, Henry, with you in the room, let's not waste the opportunity for some market research. Pull back out your mobile phones, direct them to app.eao.org, push the interaction button, and please answer question number 5. And these next 3 questions are all about the future when you are about to walk out of this room. Do you plan to switch to guided/navigated implant surgery within the next 2 years? Option number 1, I'm already using it. Option number 2, I will invest in it. Number 3, I am not sure. Of option number 4, not at all, regardless of what I've heard in the last 75 minutes here. Looking forward to see some results when we have the votes coming in, before we bring this whole Congress to a nice close with our best applause we have. Here we see over half of the room, people in the room who vote are already using it. There's some uncertainty, but there's very few people answering not at all.
Yes, but 25% still are a little bit
unsure or not at all.
Yes, yes, yes.
The next question is question number 6, should appear in your mobile phone right now. Do you plan to switch to optical impression within the next 2 years? Once again, maybe you're the one already using it. You should have voted that before. Or maybe you say, well, I wasn't using it, but I will definitely invest in it. Or you're still on the fence. You're not sure, or you are sure, and you say, no, not at all. Let's see what the audience who is participating with us is voting on those 4 options. And here we see again, well, I think it's in line with our opening polls.
Yes, even
already
better,
using it, even better, yeah. Some people realized all this talk about iOS devices. No, we are talking about intraoral scanners. It's not about Android versus iOS. Sorry, couldn't let that one go. Let's go to the last question for our audience. Do you plan to switch? There we are, Stefan. Do you plan to switch from external lab procedures to chairside milling within the next 2 years? Again, you should be familiar with the 4 answering options. Are you already doing that, chairside milling? Are you planning to invest in it? Are you not sure yet? Or you are pretty sure, you said, no, I will not move from my external lab procedures to chairside. Let's see what the audience in this room on this Saturday afternoon is thinking about this. Ooh.
Yes.
Stefan, it's a bit in line with your first emotion when you were listening to Henry.
But the thing is, you know, Garrett, that these are topics that are discussed every day. I think the interesting part of this session was that we had a chance to look at it from different aspects in the hands of 2 great experts. So it's something that we have all discussed or we have all thought about in our minds, but now we have some more effective data to take our decisions and to modify our attitudes in the future.
Right.
So thank you very much, dear colleagues. With this, the Congress comes to a end.
Almost, but not before we invite the chair of this wonderful Congress here in Geneva, and I invite you all to be part of this official moment and really start to gather all your appreciation of all the things you have experienced here for the last 3 years. Irina Seiler, please join us.